Good evening, everybody, and welcome to this monthly MedEClasses postgraduate lecture series in which we are going to talk about a very important topic of hypokalemia. This lecture series, as we've discussed earlier, is an event which we organize monthly, and we propose to have 36 such sessions covering the entirety of postgraduate relevant pediatric endocrinology. So we have been running on electrolytes for these last few sessions. We're on hyponatremia, hypernatremia, and today we talk about hypokalemia. Now, hypokalemia is very common in terms of pediatric practice, but Dr. Manoj, what do you think are the major causes? So today I'm joined by Dr. Manoj Agarwal and Dr. Bajpai Yadav, who are fellows in pediatric endocrinology, who will be part of this program. So Dr. Manoj, what do you think in terms of from a pediatrician's perspective, how common are endocrine causes of hypokalemia?
So if we talk about the pediatric perspective, then the diarrhea and vomiting is major cause of the hypokalemia. So it is a normal in the for the pediatric, but we have to keep our eye and ear open to not miss the sinister pathology like RAS excess or tubulopathy or the Bartter or Jitterman syndrome, because this can cause the persistent and the chronic hypokalemia. So identifying etiology is a very major cause in this particular concern.
So, Dr. Vibha, what do you think are the pointers when somebody should start thinking that, okay, this is not a simple cause of hypokalemia, we are thinking of some form of a endocrine cause of hypokalemia?
Like when any patient comes with like a failure to thrive, not gaining weight and having like malnutrition and having multiple fractures, like in the case of RTA, it could be the cause of one of the hypokalemia. And we should not miss it because it would lead to very life-threatening complications of metabolic acidosis. And another another symptoms could be like paralytic ileus or having this could be many problems.
What would you look at in terms of hemodynamic status, which will tell you the likelihood of an endocrine cause? Which parameter you will look at?
So for the hypokalemia, there will be for the ECG you are talking about?
No. So I'm talking about what will be the pointer that this is an endocrine cause. So if this thing is high, you start thinking this is an endocrine.
Sir. Basically, BP. We will look for the BP. If it is high, then definitely there is the RAS axis. It is involved here. And
yes. So as Dr. Manoj and Dr. Vibha have said that the hypokalemia is very common in pediatric practice. We talked about hyponatremia. It is also common, but there are much more endocrine contribution, particularly of SIADH. Hypernatremia, which we discussed in the last session, is usually because of dehydration, or a chronic hypernatremia would basically is equivalent to diabetes insipidus. This is what we discussed. But when we talk about hypokalemia, there are many more acute causes. You may have a gastrointestinal loss, you may have diuretic use, you may have urinary loss, which will be more common. But if you have chronic hypokalemia with hypertension, along with that severe failure to thrive in polyuria, you start thinking of tubulopathies and endocrine causes which may become relevant from that perspective. So we'll be starting the session. We'll talk initially about pathophysiology. Then Dr. Manoj will talk about etiology, followed by assessment and management by me. And Dr. Vibha has collated a number of interesting questions which are relevant from postgraduate perspective, which can come from that perspective. So as we have discussed, hypokalemia is a common finding, but often it becomes like a diagnostic challenge, which is there in that perspective. So one needs to be aware and open to the various possibilities which are there. So we had this 2-year-old boy who presented with failure to thrive and had a significant failure to thrive in the form of weight of only 8 kilograms and compromised height with hypokalemia. Now, based upon the workup, and we'll discuss subsequently as to how blood gas becomes very important in here in terms of evaluation, the patient had alkalosis, which was quite significant, and further workup showed a normal blood pressure. Along with that, a hypocalciuric situation and a low magnesium. So we had a child who has hypomagnesemia with failure to thrive with hypocalciuria. The most common diagnosis people make is that of Jitterman syndrome. But the challenge in the evaluation of hypokalemia is not to rush towards unusual causes, because common causes are more important. So what we should consider here was to look at malnutrition. So when we looked at the fractional excretion of magnesium, which was low, it suggested that this was primarily a cause of malnutrition causing hypokalemia rather than a tubulopathy. So we need to have a comprehensive assessment with regards to the evaluation before we reach to a particular cause, because that cause deserves a specific treatment in that perspective. So as discussed, we'll touch base about pathophysiology, followed by criteria and etiology, management, and then we'll go forward from that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got validated modules with regards to different aspects of pediatric endocrinology. We have got our e-learning portal on YouTube, where now there are a large number of videos, and you can also access our courses, which provide validated tools for assessment and evaluation. We have specific courses in the form of fellowship in pediatric endocrinology and pediatric endocrinology for postgraduates, cater to specific needs of people at different levels of careers. We do conduct 3 programs on a regular basis in the form of a pediatric endocrine grand round, a pediatric endocrine focused discussion, and this PG lecture series, which cover entirety, and these are available routinely on Zoom and YouTube. All the recordings are there. There are 2 publications which are available through our website, as well as the Kindle book reader and a mobile application, which helps in terms of assessment and diagnosis. From a pediatric perspective, I would say the most common causes would be, of course, the gastrointestinal loss, malnutrition, hypomagnesemia. But if you're talking about chronic, we are talking more in terms of RAS abnormalities, more in terms of tubulopathies, more in terms of RTA. So we'll now go forward in terms of assessment and management of hypokalemia. So the 3 key questions which a pediatrician has to answer in a patient with hypokalemia: is it really hypokalemia? If it is hypokalemia, what is the site of potassium loss? And finally, what is the final cause in that regards? So hypokalemia can present with multiple manifestations, and the major effect of potassium is, of course, on the heart. And we know that if you have severe hypokalemia, it can cause cardiac arrhythmia and sudden death may also happen. There are also effects in terms of muscular functions and renal concentration mechanisms as well. So the most common presentation in terms of renal is in the form of polyuria, because it induces a secondary nephrogenic DI-like scenario. There would be issues with regards to the ECG changes, and if we are not picking it up at the right time, there will of course be arrhythmia which may happen, which may be life-threatening, which may include AV block and even fibrillation in that regards. Now, muscular weakness is a classical presentation. This is very, very common in the form of neck flop, ascending paralysis, and we all know about hypokalemic paralysis, which can cause. Paralytic ileus could also be an important manifestation in that regards. Persistent hypokalemia, hypomagnesemia, and hypophosphatemia can also induce rhabdomyolysis, which we have discussed a lot in the setting of diabetic ketoacidosis, which can be a very significant issue in terms of causing induced renal dysfunction in that regards. Now, very importantly, it's not just the absolute level of potassium, but how rapidly the potassium levels have fallen is also important. So if we now look at the various levels, generally symptoms do not happen before we have levels which are around 3 or below. Polyuria typically happens below 3. If we talk about muscular problem, again, at around 2 to 2.5, you will have weakness, ileus, and spasm. And the ascending paralysis and rhabdomyolysis suggests a very severe form of hypokalemia in the form of 2 millimoles or lower. And cardiac abnormalities, the ECG changes typically from around below 3 in that regard. So generally, if we are identifying potassium not in a routine fashion, it's going to be very, very severely affected in that regards. Now, we also need to understand that the criteria will differ as different ages, particularly for preterm babies who have got a higher level of potassium in that regards. The term neonates, the levels are slightly lower, 3.7. And infants, again, we go back to the 4 criteria in that setting. So we need to use age-specific criteria in that scenario to identify. Very importantly, if you're using a blood gas analyzer, there will be a falsely low level of potassium in the whole blood by 0.4 millimoles per liter, which you have to correct out in that scenario and that regards. Remember, potassium is an intracellular ion. So if you are squeezing the sample, if there is a tourniquet, you will have an intracellular release. If there is a very high cell count like leukocytosis, like leukemia, there can also be a falsely high potassium, which can cause a confusion in that scenario. Now, once we have confirmed that this is hypokalemia, the next big question is, what is the site? Is it gastrointestinal or urinary? because cellular shift will be happening in a setting of DKA, in the setting of paralysis, in the setting of insulin, a very rapid scenario. So main question is it gastrointestinal or urinary? The key parameters to look there is urinary potassium. As I already mentioned, that if the urinary potassium is less than 20, that is if you have low blood and low urinary potassium, that is a normal response. But if you are persisting to lose potassium in the urine despite hypokalemia, it indicates a renal loss. The other parameter to look at is urinary potassium to creatinine ratio, which is equivalent to around 15 milliequivalents per gram, which can be the, and importantly, this has to be corrected for the level of urinary output. So urinary potassium is an important investigation which will help us classify a gastrointestinal versus a renal loss in that scenario. Now, once we know the site, the next big question is what is the cause of hypokalemia? So go for a comprehensive clinical evaluation. If there is significant failure to thrive, think of renal tubular acidosis, tubulopathy, or malnutrition as the primary cause. Hypertension, as Dr. Vibha was talking about, if it's present, it suggests an increased effect of the RAS axis. Intake of drugs which can cause hypokalemia in the form of diuretics, amphotericin B, cisplatin, and risperidone, which is very, very important. DSD, again, as we have discussed earlier, Dr. Manoj talked about if you have a XX DSD with hypokalemia, think of 11-hydroxylase deficiency. XY DSD with hypokalemia, think of 17-hydroxylase deficiency in that scenario. Take a comprehensive history of diarrhea and vomiting along with respiratory features, and sometimes thyrotoxicosis can also cause hypokalemia, which we need to be aware of in that regards. So the most important investigation in a child who presents to you with chronic hypokalemia is the blood gas. Anybody who has hypokalemia should have metabolic alkalosis. If you have metabolic acidosis with hypokalemia, you are largely dealing with either a gastrointestinal loss, diarrhea, or a renal tubular acidosis. Rarely this may happen with acetazolamide intake, which effectively causes a sort of a RTA, or if there is a ureterosigmoidostomy. So hypokalemic acidosis, RTA versus GI loss, go ahead with urinary anion gap in that setting. If you have alkalosis, you have got huge number of possibilities. The next step is to look at blood pressure, and then from there, the renin, angiotensin, aldosterone evaluation. Very importantly, sodium levels, if you have both hyponatremia and hypokalemia, you are having a loss of sodium either via the intestine or via the kidneys, so tubulopathies or GI loss is what is relevant in that regards. Hypomagnesemia, anybody who has chronic hypokalemia, look at magnesium levels, and of course, look for renal dysfunction, do a complete renal function test in that regards. Now, once you have metabolic acidosis, as I said, the key differentials are diarrhea versus RTA. And here, what is relevant is the urinary anion gap. So urinary anion gap is the difference between unmeasured negative ion and the unmeasured positive ion, which in turn reflects the difference between sodium, potassium, and chloride. So it's basically urinary sodium plus potassium minus urinary chloride. In diarrhea, when we have a normal process of ammonium production, the ammonium levels will go up. So your unmeasured positive ion will go up. And in this scenario, the anion gap will be reversed. You will have a negative anion gap. So a normal compensatory response to acidosis is to try to excrete the ammonium in the urine, causing a negative anion gap. However, if you have a problem in the tubule itself, this ammonium production is defective, so you will have a positive anion gap or an increased anion gap in that scenario. So a negative anion gap in somebody who has got hypokalemia and acidosis suggests diarrhea, while a positive anion gap in the setting will suggest the possibility of a renal tubular acidosis in that regards. Now, if you have alkalosis, then your differential becomes wide. Then you have to look at the blood pressure. So if you have alkalosis with hypertension, then there are a lot of causes. And in that regards, if your renin is high, this is clearly renal artery stenosis. While if the renin is low, you're talking about low renin states. There you have to look at aldosterone. So high aldosterone, low renin, that is primary hyperaldosteronism. Think of adrenal adenoma, hyperplasia, or glucocorticoid remediable aldosteronism, as Dr. Manoj talked about. If you have low aldosterone and low renin, it basically means that either you have got an alternate form of aldosterone which is working, like DOC, which happens in 11-hydroxylase or 17-hydroxylase deficiency, or there is an apparent mineralocorticoid excess that cortisol is acting on the cortisol receptor, or there is Liddle syndrome or cortisol resistance in that scenario. So a combination of renin and aldosterone in individuals who have hypertensive alkalosis will give you the diagnosis in that perspective. What about those individuals who have alkalosis with a normal blood pressure? In that scenario, of course, you have to rule out the possibility of loss in the form of vomiting, NG aspiration, and diuretic. Once you do that, your major differentials are Bartle and Gentleman syndrome. So here, if you have hypercalciuria and hypermagnesiuria, you're usually dealing with Bartter syndrome in that regards. If you have Gentleman syndrome, you will have hypocalciuria, but your urinary magnesium will be high. If everything is low, your magnesium is low, urinary magnesium is low, urinary calcium is low, you are dealing with a primary hypomagnesemia, usually because of a malnutrition in that perspective. So as we discussed, in a child who has hypokalemia, acidosis, alkalosis will be the first thing to look at. If there is alkalosis, look at blood pressure. Blood pressure is high, look at renin and aldosterone. Blood pressure is normal, look at urinary calcium and magnesium, which will give you a diagnosis. So if we now summarize the entire disease classification, if you have a association with hypomagnesemia, think of diuretic use, malnutrition, Barters and Gentleman. There will also be low volume state with a pH of alkalosis in that regards. RAS excess will have hypertension. So hypertension with hypokalemia, of course, means RAS excess. Then you have to work up in that perspective. While if you have acidosis along with hypokalemia, you're dealing with either renal tubular acidosis or diarrhea. So the most important investigation to me is to look at the pH, look at the blood pressure, look at magnesium. This will give you the diagnosis very clearly. So the approach to hypokalemia is to first exclude diarrhea, diuretic use, or malnutrition, then do a blood gas. If blood gas shows acidosis, look at a urinary anion gap. If urinary anion gap is positive, it means that there is an impaired ammonium production, suggesting the diagnosis of a renal tubular acidosis. If it's negative, we are talking about a gastrointestinal loss. If, on the other hand, if you have alkalosis, look at blood pressure. If blood pressure is low, you have to look at low or normal, look at urinary calcium. Urinary calcium is high, this is Bartter syndrome. Urinary calcium is low, it's Gentleman syndrome. But remember, do a fractional excision of magnesium out here. If, on the other hand, your blood pressure is high, look at aldosterone. High aldosterone means primary hyperaldosteronism. Go for imaging, think of a familial cause. If the aldosterone is low, look at deoxycorticosterone. If that level is high, this is a CH variant, 11 or 17 hydroxylase deficiency. If it's normal, look at a spironolactone response. If it's present, this suggests an apparent mineralocorticoid excess. If it's absent, this is Liddle syndrome. So essentially, the major approach relies on the looking of blood gas, and then based upon that, if there is acidosis, classifying diarrhea versus RTA using a urinary anion gap. If there is alkalosis, look at blood pressure. If blood pressure is low or normal, exclude Bartter versus Gentleman. If the blood pressure is high, classify using aldosterone levels, DOC levels, and the aldosterone response into the various causes of low renin hypertension, which we'll discuss in much more detail subsequently in further modules in that scenario. So now we'll go on to cases. 2-month-old boy with failure to thrive and hypokalemia. Now, what we do here is look at blood gas. There is acidosis. So hypokalemia with acidosis. This is an important finding. The next question is, what's the anion gap? This is a normal anion gap acidosis. So what do we do here? We look at the urinary anion gap. And in this scenario, we find that the urinary sodium plus potassium is much lower than chloride. So you have a negative urinary anion gap. This is suggestive of a diarrheal loss. So very importantly, if you have hypokalemia and acidosis, do a urinary anion gap. 12-year-old girl with multiple fractures, and we can see severe bone disease, failure to thrive, polyuria, and myopathy. There is significant acidosis and hypokalemia. So acidosis, hypokalemia, failure to thrive, fractures, diagnosis is already made, but we'll go to other investigations. There is a normal anion gap. The blood gas showed acidosis. Urinary anion gap is positive, so this is RTA, and this is a classical presentation of distal RTA in that regards, which was confirmed by alkaline urine. So acidic blood, alkaline urine, problem in acidification. This is distal RTA written all over in that scenario. 3-month-old girl with significant failure to thrive and hypokalemia. Birth weight was 2,800 and only gained 700 grams since then. There is a significant alkalosis on blood gas examination, pH is 7.54. The blood pressure is normal for the age. So now we are talking about alkalosis with normal blood pressure. Now, if we talk about very early onset, our differences are limited. We are thinking of Bartter syndrome as a possibility. So look at urinary calcium. It is very, very high. It goes more in favor of Bartter syndrome. There was also nephrocalcinosis, which was there. Treatment is with indomethacin, which is going to be effective in that regard. A 2-year-old boy with failure to thrive. There is significant hypokalemia and failure to thrive. Again, the blood gas is showing that there is alkalosis. So this is an older child, older than the Bartter one, which we saw. The blood pressure is normal. There is no hypocalcemia, hypercalciuria. So a diagnosis of hypomagnesemia was made because magnesium was low. And somebody thought this could be Gentleman's syndrome. So this is the index case where we highlighted that if you have hypomagnesemia with metabolic alkalosis, failure to thrive, always exclude malnutrition, a primary hypomagnesemia. So we did a fractional excretion of magnesium, which was low, confirming that this was more like malnutrition rather than other causes in that scenario. 9-year-old boy with leg cramps. So the presentation here is different. And this presentation will tell you what is the most likely diagnosis. The child has significant hypokalemia. And when we did a blood gas, it showed metabolic alkalosis with a normal blood pressure. So again, we are dealing towards the Bartter versus Gentleman. Later presentation with leg cramps goes more in favor of Gentleman syndrome than other scenario. There is hypocalciuria and the magnesium is low. Fe magnesium is high. So this is classically Gentleman syndrome. Think Gentleman syndrome in an older individual with milder presentation with cramps, polyuria. And if you have hypokalemic alkalosis with hypocalciuria and hypermagnesuria. So essentially just like what the thiazide diuretic does in that scenario. 8-year-old boy with early puberty, height is 134, stage 4 pubic hair development, hypokalemia. The blood gas showed alkalosis. So again, hypokalemic alkalosis, there is hypertension. So this now is towards the right hand of the extreme. We have hypertensive alkalosis with hypokalemia. We need to look for the various aldosterone excess or apparent aldosterone excess like scenario. But the presentation is a clue. There is early puberty. Early puberty in a boy with hypertension, hypokalemia, alkalosis suggests 11-hydroxylase deficiency. So aldosterone was undetectable. There was interestingly cryptorchidism. So this was even more interesting. So this is 11-hydroxylase deficiency in an XX individual who has now been reared as a male because of extreme level of virilization. 14-year-old girl with delayed puberty, height is 148, stage 1 pubic hair development, potassium is low. Blood gas again shows metabolic alkalosis, so hypokalemic alkalosis. There is hypertension. So again, we're dealing with a RAS excess scenario. In this scenario, aldosterone is undetectable. So we have some other cause of RAS excess. Again, delayed puberty, sexual infantilism, hypertension, hypokalemia, direct diagnosis, 17-hydroxylase deficiency. So we thought of that, but interestingly, there was also an inguinal gonad. So this is a mirror image of the previous case, which was XX individual presenting as a male with precocious puberty. Here you have a XY individual presenting as a female with delayed puberty. So looking at puberty, looking at DSD becomes important in hypokalemia, especially if it is chronic. So this is 17-hydroxylase deficiency is in XY. DHD in that scenario. 1-year-old boy with failure to thrive and hypokalemia, the blood gas shows metabolic alkalosis, the blood pressure is on the higher side. So again, early onset hypertensive hypokalemia and alkalosis, aldosterone level is undetectable. So we're talking about something else which is acting here. So in this scenario, the DOC is also normal. There is no atypical genitalia. Our differential is Liddle syndrome versus apparent mineralocorticoid excess. And as discussed, we can do genetic studies, but a therapeutic trial to spironolactone will give us a clue. So this child responded to spironolactone, indicating that this was apparent mineralocorticoid excess in that scenario. So a systematic evaluation for blood gas, blood pressure, aldosterone is pretty much sufficient to give us the diagnosis in this scenario. 2-year-old girl with failure to thrive and hypokalemia. Here the blood gas again is showing alkalosis. Blood pressure is again high. Now the aldosterone is again undetectable. We are seeing DOC level is low. So again, a similar case as the previous one. Again, there is no response to spironolactone. So this suggests that this is an epithelial sodium chloride channel. Because it's distal to the spironolactone, there will be no response. Amiloride is what the response will be there. And this is Liddle syndrome in that scenario, what we're looking at. Now, what about management? Management of hypokalemia is not challenging. Acute treatment is indicated only if you have paralysis, arrhythmia, or significant hypokalemia below 2.5. In that scenario, you can use potassium chloride, 0.5 to 1 millimoles per liter. Aim to rise only by 0.3 to 0.5. So you don't want to increase it very rapidly. If possible, go for an oral correction. If there is no indication for acute treatment, if your potassium is less than 3, start oral potassium. More than 3, you can simply supplement with other parameters and correct the cause in that scenario. In general, oral treatment is preferred because if you give too much potassium, it may have a cardiac issue. Avoid dextrose containing fluid because that will cause insulin release and that will cause shift of potassium. If you're giving potassium more than 40, you use central line, and magnesium is required if there is a refractory case. The preparations include potassium chloride, which provides a rapid correction. Potassium phosphate is particularly beneficial in Fanconi syndrome and diabetic ketoacidosis, and potassium acetate, especially in DKA, to avoid hyperchloremic metabolic acidosis. For RTA, you have got the potassium citrate, which is quite used. Specifically, if you have RTA, you can use bicarbonate and potassium. For malnutrition, magnesium becomes important because that's an important cause here. And if there is an effective hypovolemia, give diamox and potassium chloride, which will be of effect. And if there's a RAS excess, think of spironolactone. If there is Bartle or Gentleman, indomethacin or amiloride. And if you're thinking of Liddle syndrome, you can use amiloride again. I think there was a question by Dr. Rajib about in case of hypokalemia in an infant with severe diarrhea and moderate dehydration, whether pot-chlor can be given with fruit juice or alone. So if you have significant hypokalemia and the child is accepting orally, you can give pot-chlor. I think that's a good option. Oral is always preferred and you can give with fruit juice also. There's no problem. Pot-chlor alone may also be effective. But if you have severe changes like ECG changes, if you have features of paralysis, then you might have to think of whether IV treatment is required there or not. Dr. Rajib is asking, in a male patient with AME, can decadron or amiloride be given on a long-term basis as spironolactone may cause gynecomastia? Dr. Manoj, what do you think? So in apparent mineralocorticoid excess, we said, okay, spironolactone is a good agent, but then it can cause anti-androgen.
Anti-androgen.
Which agent will you prefer?
So we have to start that molecule which don't have effect on the androgen, which don't act as an androgen antagonist. So eplerenone in this condition will be the option. So we have
what
to
about
treat
decadron? How do you think? Decadron is going to cause a lot of side effects. So dexamethasone, of course, is not something which we will prefer in this scenario. And the use of steroids in this scenario is anyway a debatable thing in that regard. You're basically suppressing the production of cortisol. Amiloride can be given, but in our experience, the amiloride response is not as good as the response of mineralocorticoid antagonists. So better would be to use eplerenone if you are concerned about gynecomastia in that.